faculty member, and certainly the audience who is shockingly still in the room at 7:15 p.m. So thank you all.
Thank you very much. Can you stay for any question, maybe?
Yeah, please.
Any questions for Dr. Saris? A quick one, if it is any. We thank you that we have you here.
Thank you.
Next speaker is Dr. Pαυλιδέλης, and as far as I know, he likes the closed rhinoplasty mainly, and he's going to tell us about the lateral wall management or sidewall management. Βασίλη, ελληνικά ή αγγλικά θα μιλήσεις?
Μου εδόθη εντολή να μιλήσω αγγλικά.
Okay.
Και από εδώ μπρος πίσω. Dear President, dear colleagues, I would like to share with you my experience about this difficult subject of rhinoplasty, managing the side wall of the nose. We speak about the sufficiency of the side wall, which can be iatrogenic mostly, or congenital. Είναι already εκτός. It is very difficult to have this insufficiency on the nose. You have the feeling somebody is holding your nose with a punch. All these complications of this sidewall insufficiency are mainly producing from bad operations in rhinoplasty or septoplasty. And the only way to correct these anomalies is to use cartilage or composite grafts from the same patient, autogenous grafts. Harvesting the conchal ball cartilage, it's to suggest to take as much as possible from the cartilage, so you have enough material for all your work you need to do and avoid step formation in the concha. A lot of surgeons do the incision from in front, but I think it's better to incise post-auricular. Still 100 years now is the most important and good transplant for producing your grafts you need for the revision rhinoplasty, the conchal ball cartilage. I am going to give you some examples from patients who are operated previously in septorhinoplasty with side wall insufficiency. This is a patient with 2 previous operations, and you see the postoperative result in the AMFAS photography. At the time of closed rhinoplasty, the main technique was the luxation method, delivery technique, and we did the rim incision and the intercartilaginous incision to prepare the cartilage, the low lateral cartilage. I suggest always to prepare first the mucosa and then to prepare the skin, because we have a stability and we can work better in this preparation. You see here the grafts ready to be inserted in place, and you can see the supraalar graft, the septum graft, and columella strata, and from the other side also alar graft. The same patient where you can see the supraalar and alar crease correction. I speak for this area. This is the alar crease, and this is the alar damage. Same patient in other photography, and profile of the same patient with the postoperative result. You see the tip rotation, and this ensures also the result for long-term and better respiration of the patient. I suggest to fixate these transplants in order to immobilize them and avoid hematoma or postoperative displacement. This is another difficult case with 3 previous rhinoplasties, where you can see the upper lateral cartilage collapse, the low lateral cartilage collapse, surely because of the damage of these cartilages, and we have an insufficiency in the internal and external valve. There is always a confusion in the terminology, internal, external, middle valve, further valve, etc. Anyway, there is an insufficiency in the middle and further part of the nose. Here you see again the grafts ready and prepared in their shape to be inserted in the right place after producing the pockets, the right place where they have to be inserted. This is the postoperative result. And you see all the corrections that have been done in the whole sidewall, right and left. Same patient, postoperatively, 1 year photography after the operation. You see here in 3/4 from both sides. And this is another patient with 2 previous rhinoplasties, where we see the upper and low lateral cartilage damage. And in addition here we see a polypic deformity and here a saddle deformity. They have to be corrected all together at the same operation, beginning from a straight, good operated septum, and then coming out to the functional rhinoplasty. Same grafts, in addition a radix and saddle deformity graft, which has to be inserted also in order to correct the saddle deformity of the nose. You see the postoperative result, the nose full from grafts, and a very, very normal functional and aesthetic result. Like Alfred said, rhinoplasty is an easy operation, but it's very difficult to get good results. And Tardy said as always that if you know to operate the tip, you know to operate the nose. That is right, and we can all understand that why. I spoke for congenital deformities from the sidewall first, and now I will show you how can we correct a nose. This lady has not been operated before, but she couldn't breathe and her nose was not nice aesthetically. We use the reverse technique to correct these anomalies, and we try to change from concave to convex at the low lateral cartilages. You see, the cartilages here, they have been cut and separate from their place, and after it has been sutured another cartilage graft to strengthen the cartilage in order to avoid a new collapse after the reverse technique that we used. You see here the cartilage again, ready to be inserted and be sutured in its place. You see it here in convex side before inserting it in the nose. I just described here the technique. This is the postoperative result where we corrected all these anomalies. If the problem is not only the sidewall insufficiency and the problem is also a vestibular stenosis, then these transplants are not enough to lose our problem, to solve our problems in the nose. So we have to get a composite graft. What is a composite graft? A composite graft is a graft with cartilage and skin together, not separated. We harvest this graft from the conchal ball too, and it's a very nice operation to close the defect which we left after this harvesting at the ear cartilage. You see, we go post-auricular and we make a round incision at the shape of the cartilage that we took away, and we pull through this transplant, this skin transplant, which is not 100% excised, but it has a basis like a mushroom to be nourished, and we pull it through the defect. You see here? You see the mushroom? We do that to ensure good circulation and ensure that it's not going to be necrotic. You see that in place, sutured, the post-auricular suturing and the post-operative result where we don't see the scar at the post-auricular area. And here you see you recognize easily that here the transplant are not cartilage, but the anterior side is from cartilage and skin together. This also, but not the columella graft, but the other side also composite graft. All these operations nowadays I perform with open rhinoplasty. And we explained during the course before at the cadaver where the best place to do the incision is the lowest, narrower region of the columella. This patient with also sidewall insufficiency, the upper lateral and lower lateral cartilage damage, and also saddle deformity and collapse, has been operated and corrected with open approach. You see the postoperative result, and you see that if you suture nicely, you don't see the scar. We don't have to be anxious about a visible scar at the columella by the open rhinoplasty if you really suture together the flaps very exactly. This is the patient I speak about. I tend to operate more and more open rhinoplasties now, not only in revision cases, but also in primary cases, congenital, where I have to repair exactly cartilages and other abnormalities. This is a guide where not only doctors, but also patients can read about rhinoplasty after my 30 years and more experience and over 7,000 operations. And from this place, I would like to thank the pioneers of the European Academy of Facial Plastic Surgery. With the help of them, I started 20 years ago in Greece, in Athens. You see here the date, 93. I think Professor Segas was present at this course. Today we have 2013, and you see Professor Walter and me, young, with black hair, 20 years ago, and the audience where we helped us to improve the knowledge in our country and help the ENT college to learn the rhinoplasty, which is a very, very excellent and nice operation if she is going to be well done. Except the European Academy of Facial Plastic Surgery, we have 1998 the Hellenic Society of Facial Plastic Surgery, and I am really very proud, like I told you, to see in this audience a lot of ENT colleagues performing rhinoplasties and having a big interest to facial plastic surgery. I thank you very much for your attention.
Thank you very much, Vasilis. You was in time, actually. Thank you very much. Just a quick question. In the case that you show us that you have taken the composite graft from the concha, why you shouldn't take the skin behind and the cartilage without moving the anterior part of the skin and not having to close it next?
You cannot take them separate because the risk of getting necrotic, it's bigger.
I'm not talking separate, but you can take the skin from behind the ear and the cartilage and lift the anterior skin intact and not having to cover it.
Because you have not the right curving. It's opposite curving.
The skin is behind, so you have it. You wanted to cover from outside and
from inside.
You put it inside.
From inside, okay. You have to have the curve.
Another question for Dr. Pavlidelis? Okay, thank you very much, Vasilis.
You're welcome.
Next presentation is our president, Yannis Konstantinidis, and he's going to talk to us about nasal valve problems again.